This conference will now be recorded.
Sorry. Citizen. Volume touched. Good morning, students. Good morning, students. Am I audible to you all? ఎవరు రిప్లై ఇవ్వట్లేదు ఒకసారి నీ ఫోన్లో చెక్ చేయండి సార్ అమ్మా లాస్ట్ ఇయర్ వినపడుతుందమ్మా ఫోన్లో వినపడుతుందా ఓకే ఓకే సో గుడ్ మార్నింగ్ టుడే విల్ discuss the topic of inflammation and repair. So it is very difficult to cover the entire topic in a single class. So what I was enrolled is I was asked to discuss the questions which are given for you in the last internal assessment exam, not I mean like weekly slip test exam. That is the chemical mediators of inflammation, growth factors involved in tissue regeneration and repair, role of interleukins in acute inflammation. I will cover in chronic inflammation also. Role of interleukins in chronic inflammation. About chemotaxis and healing by secondary intention complications of wounding. Okay, let us start with the chemical mediators which are involved in inflammation. Okay, so from where they are actually they are derived. Okay, so they derive from plasma and WBCs, which is leukocytes, and at the local tissue, and from the bacterial products. Okay, so they have a short lifespan, so they acts within seconds to minutes, and they may have local and systemic effects, just like histamine, which can produce local signs of itching and systemic signs of anaphylaxis. So these are the key points regarding the chemical mediators of inflammation. So one is they derive from plasma, WBCs, local tissue, and from the bacterial products, and they have a short lifespan, and they have local and systemic effects. Okay, so let us see the cell-derived chemical mediators and the chemical mediators which are there in the plasma and which are secreted from the liver. Okay, so from mast cells, basophils, and platelets, so they have a preformed mediators within the cytoplasm, which include like histamine in mast cells, basophils, and platelets. Whereas there is serotonin within the platelets, and within the neutrophils and macrophages, there are lysosomal enzymes. From all leukocytes, platelets, and endothelial cells, we get prostaglandins, leukotrienes, platelet activator factors from endothelial cells and leukocytes, and reactive oxygen species derived from all WBCs. Macrophages contain nitric oxide, and cytokines are derived from lymphocytes, macrophages, and endothelial cells. And factor 12, the coagulation factors are, you know that the coagulation factors are synthesized from the liver, and they will be there in the plasma, and they act wherever there is a site of inflammation. So apart from coagulation cascade, so there is one more system, there's complement system. Again, these complement factors are synthesized from the liver, and they act at the site of inflammation. So these are the various chemical mediators which play an important role in inflammation. So let us see where from they are derived, how they act, all those things. So our body constitutes tissue, you know that everybody knows it actually. Our entire skeleton is constitutes skeleton, I mean tissues, and tissues contain cells. Cells contain cell membranes, nucleus, cytoplasm, and various cellular organelles. Okay, so this arachidonic acid metabolites are derived from the cell membranes with the help of enzyme called phospholipase. So from the cell membranes, cell membrane phospholipids, with the help of enzymes called phospholipases, we get arachidonic acid metabolites. So which include, so with the help of other lipoxygenases, so we may get hydroxypentaicosaturonic acid or hydroxyicosaturonic acids. Suppose if the enzyme 5-lipoxygenase acts on this arachidonic acid, so we get 5-hydroxypentaicosaturonic acid and 5 icosapentaenoic acid. So from hydroxy pentaicosatetraenoic acid, we get leukotriene A4, leukotriene C4, leukotriene D4, leukotriene E4. And whereas from 5-hydroxyicosapentaenoic acid, we get leukotriene B4. Okay. From HET, we get B4. From whereas HPET, we get A4, C4, D4, E4. So what this will do is this leukotriene B4 will play an important role in chemotaxis, whereas the rest will play in vasoconstriction, bronchospasm, and increased vascular permeability. So suppose the enzyme, if cyclooxygenase acts on the arachidonic acid metabolites, so what we get is prostaglandin G2, prostaglandin H2, and from prostaglandin H2 we get prostaglandin I2, which is otherwise called as prostacyclin, so which causes vasodilation and inhibits the platelet aggregation. Whereas the thromboxane A2 will cause vasoconstriction and promotes platelet aggregation. Prostaglandin H2, from H2 we get again two more entities, prostaglandin D2 and prostaglandin E2, so they cause vasodilatation and increased vascular permeability. And from hydroxypentaicosatetraenoic acid, we get two more lipoxins with the help of enzyme 12 lipoxygenase. That's lipoxin A4, lipoxin B4, which inhibit neutrophil adhesion and chemotaxis. Okay, so different arachidonic acid will have a metabolites which are derived from arachidonic acid metabolism will have different functions in the inflammation. Okay, so we have to remember each from which enzyme, so which metabolite is derived, and by what pathway it was derived, and what is the function. So there is no other option we have. You have to remember these things. So prostaglandin I2, D2, E2 will cause vasodilation and increase vascular permeability, whereas thromboxane A2 will cause vasoconstriction and promotes platelet aggregation. Okay, whereas lipoxin A4 and B4 will inhibit neutrophil adhesion and chemotaxis. Leukotriene C4, D4, E4 will cause vasoconstriction, bronchospasm, increased vascular permeability. Whereas leukotriene B4 will cause chemotaxis. Okay, so these are in briefly about the metabolites which are derived from the arachidonic acid metabolism and from the cell membranes. So the same we discussed. They have diverse function. So vasodilation is caused by histamine, nitric oxide, prostaglandin I2, E1, E2, D2, and whereas vasoconstriction is caused by thromboxane A2, leukotriene C4, D4, E4, and the increased vascular vessel permeability is by histamine, bradykinin, leukotriene C4, D4, E4, and C3A, C5A, and prostaglandin E2, bradykinin will produce pain, and prostaglandin E2 interleukin TNF will cause fever, whereas C5A, leukotriene B4, interleukin 8, hydroxypentaicosatetraenoic acid will cause chemotaxis and leukocyte adhesion. These are the various diverse functions caused by different chemical mediators which are involved in inflammation. The same thing in the form of tableted form. I'm skipping it. So apart from that, so we have other entities like bradykinin, chemokines, complement. So this again we will discuss. This already we discussed histamine, serotonin, where from it is secreted and what it will do. The bradykinin is a product of kinase system activated by factor 12. It causes vasodilatation, increased vessel permeability, and pain and bronchoconstriction. Okay, so this is responsible for pain and bronchoconstriction during anaphylaxis. Chemokines derived from leukocytes and endothelial cells, and they activate neutrophil chemotaxis. So because of that, neutrophils will migrate to the site of acute inflammation. The complement is synthesized in liver, and the complement products like C3A, C5A, otherwise called as anaphylatoxins, and stimulate mast cell release of histamine. Whereas C3B will do the opsonization. Okay, so it will target the C3B component will target the bacterial cell wall, and it is making tasty for the phagocyte to absorb or eat. So whereas the C5A will cause activation of neutrophil adhesion molecules and chemotaxis, whereas C5 to C9 will cause membrane attack complex and cause cell lysis. The histamine serotonin we already discussed. Let us see various cytokines which are involved in inflammation. This is one of the questions given yesterday, role of interleukins in acute inflammation. So let us talk about interleukin 1 and TNF. So it is derived from the lymphocytes, macrophages, and endothelial cells. It initiates prostaglandin E2 synthesis in the antihypothalamus, leading to the production of fever. Okay, so this is the reason why we get fever. Okay, during the process of inflammation. Okay, because of increased synthesis of prostaglandin E2. So they also activate endothelial cell adhesion molecules, increase liver synthesis of acute phase reactants such as ferritin, coagulation factors, and C-reactive protein. So nowadays, everybody is asking for ferritin, C-reactive protein, and interleukin 6. The reason being, so in patients with COVID-19, this will be elevated: ferritin, interleukin 6, and C-reactive protein, and one more is D-dimer. So there is increased release of neutrophils from bone marrow. So all this is caused by the interleukin 1 and tumor necrosis factor. So interleukin 6 is secreted by the liver, and so it is involved in acute inflammation, and there is increased production by the liver and acts as acute phase reactant. And interleukin 8 acts as chemotactic agent, whereas nitric oxide will cause endothelial, release from endothelial cells and macrophages will cause vasodilatation, and of course in macrophages it acts as a bactericidal agent, usually derived from macrophages and endothelial cells, and free radical gas released during conversion of arginine to acetylene by nitric oxide synthesis. This is how it is generated. Then let us talk about interleukins, which play an important role even in chronic inflammation. One is interleukin 12. It is derived from dendritic cells and macrophages, and it will cause increased production of interferon gamma. What interferon gamma will do is, it is usually produced from T lymphocyte and NK cells, and it will cause activation of macrophages. See, interleukin 12 is produced from macrophages, and it will cause release of interferon gamma. What interferon gamma will do is, it in turn activates the macrophages to release further. Okay, interleukin 17 is again derived from T lymphocytes, and it will cause recruitment of neutrophils and monocytes. So let us talk something about nitric oxide. So I already told you now how nitric oxide is synthesized. Nitric oxide is synthesized from the amino acid arginine. Okay, with the help of enzyme called nitric oxide synthase. Okay, again nitric oxide synthase is of two types actually. So one is normally available nitric oxide synthase, and one more is the inducible nitric oxide synthase, actually, which is there within the macrophage, and actually it plays a very crucial role in bacterial cell activity. Okay, the nitric oxide which is there in the endothelial cells will be actually generated by the conversion of arginine to acetylene with the help of the nitric oxide synthase. That is one enzyme, and other one is the inducible nitric oxide synthase during the function of this bacterial cell activity. So this nitric oxide will be converted unite with the free radical, and it will form one oxygen atom will form a free radical, and it will convert into nitrogen dioxide, and it will lyse the bacterial agent. Okay, so that's why it has a bactericidal activity. Okay, let's talk something about complement. So we have three pathways regarding complement activation. One is alternate pathway. Directly microbe will come and activate the complement pathway. There is alternative pathway. Sometimes the antibodies are produced against the microbial peptides, and the classical pathway will be activated. And one more pathway is the lectin pathway. So the mannose binding lectin pathway will activate the complement, and it results in formation of a membrane attack complex, and you will cause lysis of macro, or it will generate a C3b which acts as opsonin, and it will help in the process of phagocytosis, and the complement products like C5a, C3b will recruit. They act as chemotactic agents for neutrophils, and they recruit the neutrophils, and they activate the leukocytes, and it will cause the destruction of microbes by neutrophils. So by these three processes, the complement play an important role in acute inflammation. So let us read the theory about the biological functions of complement system. In inflammation, C3a, C5a, C4a, so they are otherwise called as anaphylatoxins. They stimulate histamine release from mast cells and thereby increase vascular permeability and cause vasodilatation. Whereas C5a is a powerful chemotactic agent for neutrophils, monocytes, eosinophils, and basophils. And C5a activates the lipoxygenase pathway of arachidonic acid metabolism in neutrophils and monocytes, causing further release of inflammatory mediators. And C3b acts as an opsonin, I already discussed with you, and it will help in the phagocytosis. And they also form this membrane attack complex and will cause the cell lysis. So this is the role of the complement system. Let us see the kinin and coagulation cascades. The factor 12, so which is activated, will activate the factor 2, and it will convert the prothrombin into thrombin, and thrombin will convert the fibrinogen into fibrin. And apart from that, it will also activate the pre-kallikrein into kallikrein, and kallikrein will activate the high molecular weight kininogen into bradykinin, and bradykinin will cause, you know, that it will cause fever, bronchoconstriction, vasodilation, all those things. And this fibrotic system will break the plasmin, and it results in increased D dimers. This also, you know, everybody is doing D dimers. There's a reason. So the activation of the coagulation system. So all this will play a very important role in inflammation. Next, chemokines. Okay, so the chemokines will play an important role in chemotaxis. They act as chemoattractants, and they stimulate the leukocyte recruitment in sites of inflammation. So they're usually classified into 4 groups. That is CXC chemokines, they're otherwise called the alpha chemokines. Example is interleukin 8. So what is meant by the CXC? So X means that there is only one amino acid between the 2 cysteine groups. Okay, so whereas CC, there is no amino acid between 2 cysteine residues. Okay, which is called as beta chemokines, which include monocyte chemoattractant protein 1, eotoxin, MIP, alpha, and arantase. Whereas C chemokines are otherwise called as gamma chemokines, which is the example is lymphotactin. Whereas CX3C chemokines, in which there is a 3 amino acids between the 2 cysteines, which example is the fractalkine. These are the various chemokines which play an important role in, which acts as a chemoattraction, and play an important role in acute inflammation. Next, the neuropeptides, substances like substance P and neurokinin A, they're usually produced in the central and peripheral nervous system, and they have many biological functions like transmission of pain signals, regulation of blood pressure, stimulation of secretion by endocrine cells, and increase vascular permeability. So that's all about the chemical mediators involved in the role of inflammation, and the role of interleukins, as I explained in the inflammation. And let us talk something about chemotaxis also. Okay, what is meant by chemotaxis? Neutrophils follow the chemical gradients that lead to the infection site. The chemotactic mediators bind to neutrophil receptors like C5e, leukotriene B4, bacterial protection, interleukin 8. Binding causes release of calcium, which increases the neutrophil motility. Okay, so this is how the chemotactic agents are attracting the inflammatory cells like neutrophils, and they will get activated towards the site of inflammation. So let us see what is happening within the blood vessel during the inflammation. The leukocyte, usually in a blood vessel, the leukocytes are at the center of the flow. Just lateral to it are the RBCs, and the platelets are very close to the endothelial cells. This is how they flow in a blood vessel. So what happens during the time of acute inflammation is, so there is a break in the endothelial space. The neutrophils which are there in the center will come to the periphery, and they bind to the selectins which are there on the endothelial cells, and they transmigrate, and they bind with the endothelial cells with the help of integrins, and they migrate into the area where there is a inflammation. Okay, they migrate into the connective tissue after breaking the endothelial the gap between the blood vessels. Okay, so and they reach the site of inflammation. The leukocytes first roll, then become activated, then adhere to the endothelium, then transmigrate across the endothelium, pierce the basement membrane, and migrate toward the chemoattractants emanating from the source of injury. This is how the neutrophils will migrate from the center of the blood vessel into the site of need, wherever there is wherever there is an inflammation, wherever there is injury, wherever there is trauma, whatever something happens, the neutrophils from within the blood vessel, they go and they recruit at the site of inflammation. For this, what plays an important role is the chemokines. So I already explained the different types of chemokines: CXT, CC, and CX3C chemokines. So examples also I quoted: CX3C fractalkine. So these are all important because you may get in MCQs. C chemokine is a lymphotactin, and CXC is interleukin 8. CC is MCP1 eotoxin, maybe an alpha and arantase. Okay, because of the help of chemoattractants, they migrate to the site of inflammation. Okay, so that's all about chemotaxis and role of interleukins in acute inflammation and chemical mediators which are involved in inflammation. So let us discuss about healing, wound healing. So first, I will actually the question is about healing by second intention and complications of wound healing. So what? So in order to you to understand second intention, but I should teach you what is the first primary intention. So I will try to cover both primary intention, second intention, and of course the complications of wound healing and various growth factors involved in tissue regeneration and repair simultaneously. Okay, let us start. What happens when there is a if there is a clear cut surgical wound? Okay, so what happens during day one, what happens in day two, day three? You see, so in day one what happens is, see, apart from the cells within the blood vessel, we have a lot of plasma within the uh, blood vessel. Okay, what plasma contains various coagulation factors. Okay, so what happens is, there is a whenever there is injury, everybody knows that there is a blood will clot at the site of injury. Initially blood will go. Okay, everybody knows it. During injury what happens is blood will flow. Okay, so blood will go for a couple of times. Then after a certain period, like after the bleeding time ends, what happens is there is a formation of a clot. So initially there is a formation of a bleeding clot, so our hematoma will develop. So what happens, the neutrophils will infiltrate the wound margins. There is increased mitotic activity of basal cells as squamous epithelium in the opposing wound margins during the day one. So whenever this is about the wound healing by primary intention occurs in a clear-cut surgical wound. It won't occur in a diabetic foot ulcer or on something else. So primary intention occurs in a clear-cut surgical wound. Everybody remember this point. Okay, neutrophils will infiltrate the wound margins. There is increased mitotic activity because we approximate the skin margins, and there will be increased mitotic activity of basal cells in the opposing wound margins. In day two, the squamous cells form opposing basal cell layers migrate under the fibrin clot and seal up the wound after 48 hours. So within 48 hours, the surface of the wound will be sealed. And then what happens is, macrophages emigrate into the wound. On day three, granulation tissue begins to form. There is initial deposition of type 3 collagen begins, but does not reach the incision site. Macrophage will replace the neutrophils on day 3. Okay, so first 3 days, so there will be a lot of acute inflammation, and that's the reason we'll have a lot of pain during first 3 days after surgery. From day 3, you can mobilize, you can just walk nearby distances, you will have less pain. Whereas in day 1, day 2, you will have a lot of pain. You can't even get up from your bed. So this is because there is a lot of acute inflammation will be there, and a lot of the pain producing prostaglandins, and of course the bradykinin will be released at the site of acute inflammation. And what happens is, you can't even stand from the bed. Whereas day 3, what happens is, the neutrophils will be replaced by macrophages, and slowly you can move, you can walk. Days 4, 6, what happens is, granulation tissue formation peaks and collagen reduces the incision site. Whereas in the week 2, the collagen compresses the blood vessels in fibrous tissue, resulting in reduced blood flow, and there is a tensile strength of around 10% during the week 2. Whereas in the month 1, the collagen remodeling of the wound occurs with replacement of type 3 collagen by type 1 collagen, which has having high strength. So the tensile strength increases, reaching 80% within 3 months, and scar tissue is devoid of adnexins such as the hair, sweat glands, and inflammatory cells. This point you should remember. The scar tissue is devoid of adnexal structures like hair and sweat glands. So this is how the primary, whenever there is the clear-cut surgical wound, what happens? The wound area is sealed by a blood clot, and neutrophils will migrate. The blood vessels within 24 hours, in 3 to 7 days, there is a formation of a granulation tissue. The basal cells will try to seal the wound, and slowly within weeks, what happens is, the collagen, the type 1 collagen will be replaced by the type 3 collagen, which is having high tensile strength, and within 3 months, what happens is, the wound will get a tensile strength of around 80%. The wound healing by primary intention occurs in a clear-cut surgical wound. I'm repeating again. Whereas in diabetic ulcers and other wounds. What happens is the wound heals by second intention. Let us see what is the difference between the primary intention and secondary intention. So there will be more intense inflammatory reactions. So usually the wound healing by second intention occurs when there is no approximation between the two skin surfaces. Okay, like diabetic foot ulcers, like when there is a burn injuries. So what happens in burn injuries? The surface epithelium will be lost. The depending upon the percentage of the burns. So it heals slowly. So the wound heals by secondary intention. Okay, there is a more intense inflammatory reaction than primary healing. There is increased amounts of granulation tissue formation than primary healing, and there is a more amount of wound contraction because of increased number of myofibroblasts in the second. These are the three important. Otherwise, the rest are all same. The basal cell regeneration and repair of the epithelium, granulation tissue formation, neutrophils infiltration, macrophages infiltration, everything is same except that there will be more amount of inflammatory reaction, there's more amount of granulation tissue formation, and there is a more amount of wound contraction in secondary wound healing by second intention. So this is a the photograph of a pressure ulcer in the skin, usually seen in diabetic patients. You see the surface epithelium is wide apart, and at the ulcer side there is a lot of inflammatory granulation tissue. And this is how the granulation tissue looks. Okay. Yeah. So what does the granulation tissue contains? A numerous blood vessels, edema, a loose extracellular matrix containing occasional inflammatory cells, and collagen is stained blue by trichome stain, and you can see minimal mature collagen can be seen in this. So whereas the mature scar tissue is stained with a lot of blue in it. So this is how the wound healing, the phases of wound healing. So during initially there is a clot formation, chemotaxis, and a lot of inflammation. Later on, proliferation of the epithelial cells, angiogenesis, and matrix, collagen matrix. There will be reepithelialization, angiogenesis, and granulation tissue, and there is a provisional matrix formation, collagen matrix formation. Whereas later on, there will be a maturation of collagen. Type 1 is replaced by the type 3, and there is extracellular matrix deposition, there is a tissue remodeling, collagen matrix, and there will be wound contraction. These are the different phases of wound healing. Let us see the growth factors which are involved in tissue regeneration and repair. So one first and foremost important is the vascular endothelial growth factor. It stimulates angiogenesis, particularly in the heart, during the repair of the tissue, and during the cancer, the neoplasia. Okay, so what happens in embryonic angiogenesis, particularly in heart, and by repair of tissue, and even in neoplasia. So there is a endothelial cell proliferation and blood vessel proliferation from the pre-existing areas. Whereas in other conditions, the endothelial cell progenitors will migrate, and they stimulate the production of new blood vessels. See here, one is by the capillary supporting angiogenesis from the pre-existing vessels. So see from a single vessel, how many capillaries are generated during angiogenesis with the help of the vascular endothelial growth factor. And sometimes what happens is the endothelial progenitor cells which are there in the bone marrow, they migrate and they promote the formation of the new capillaries. Okay, so this is how the new vessel formation occurs. The one is what are the various stimulation factors which include TNF, tumor necrosis factor, which is released by the macrophages, hypoxia-inducible factor released by cells during hypoxia. It will promote the angiogenesis. Next is fibroblast growth factor. So it is chemotactic for fibroblasts and stimulates keratinocyte migration, angiogenesis, and wound contraction. And epidermal growth factor, it stimulates keratinocyte migration and granulation tissue formation. Next is the platelet-derived growth factor. It is chemotactic for neutrophils, macrophages, fibroblasts, endothelial cells, and helps in angiogenesis. And of course, those smooth muscle cells. Smooth muscle cells are there within the blood vessels. The smooth muscle proliferation is promoted by the platelet-derived growth factor. The transformed growth factor beta is again chemotactic for macrophages, lymphocytes, fibroblasts, and smooth muscle cells. And interleukins like interleukin 1 stimulate synthesis of metalloproteinases, so enzyme containing trace metals, and stimulate synthesis and release of acute phase reactants from the liver. And tumor necrosis factor activates macrophages, stimulates release of acute phase reactants. These are the various growth factors and interleukins involved in tissue repair. Okay, so apart from this, so other growth factors like heparin binding epidermal growth factor, it will help in keratinocyte replication. Hepatocyte growth factor enhances proliferation of hepatocytes, epithelial cells, and endothelial cells, increase cell motility and keratinocyte replication. And keratinocyte growth factor, also called fibroblast growth factor 7, it stimulates keratinocyte migration, proliferation, differentiation. And we already discussed about tumor necrosis factor. And whereas cytokines, other than the growth factors we discussed, include for monocyte chemotaxis, chemokines, tumor necrosis factor, platelet-derived growth factor, fibroblast growth factor, and transform growth factor beta will help. For fibroblast migration, so all this will help. For keratinocyte replication, all this will help. Angiogenesis, vascular endothelial growth factor, angiopoietins, fibroblast growth factor will help. For collagen synthesis, transformed growth factor beta and platelet-derived growth factor will help. For collagen secretion, platelet-derived growth factor, fibroblast growth factor, tumor necrosis factor will promote, whereas the transformed growth factor beta will inhibit the collagenous secretion. Okay, this you have to remember. Okay, what are the various factors that impair healing? So one is persistent infection, which is the most common cause of impaired wound healing. The most common pathogen involved is the Staphylococcus aureus. And second is the metabolic disorders like diabetes mellitus, which increases susceptibility to infection by decreasing blood flow to tissue and increasing tissue levels of glucose. The third thing is glucocorticoids. They interfere with collagen formation and decrease tensile strength. Occasionally, if used along with antibiotics, it prevents the scar formation. Like example, bacterial meningitis. Next is nutritional deficiency, like decreased protein. So malnutrition will again impair the wound healing. Vitamin C deficiency, because decreased hydroxylation of proline and lysine causes decreased tensile strength in collagen owing to loss of linkage sites between alpha chains. And trace metal deficiency like copper and zinc deficiency leads to decrease the crossing of alpha chains in collagen, and zinc deficiency leads to defects and removal of type 3 collagen in wound removal. Okay, so all these things you should take care in the post-operative period. Okay, you should control the infection, you should control the sugar levels, but you should, whenever there is required, you should treat with glucocorticoids, and you should support, give good protein diet, and you should also supplement with vitamin C tablets, and you should treat with multiple multivitamin tablet because of to prevent the trace metal deficiency. So let us see what are the complications. So this is also part of the question involved in your slip test. The complications in wound healing is, one is due to inadequate formation of granulation tissue or assembly of scar can lead to two types of complications. One is wound dehiscence and ulceration. So what is meant by dehiscence or rupture of wound? It's most common after abdominal surgery and is due to increased abdominal pressure. So mostly due to vomiting or coughing or ileus, and it can generate mechanical stress on the abdominal wall. And wounds can ulcerate because of inadequate vascularization during healing. Okay, so one is because of inadequate formation of granulation tissue, and because of various other mechanical causes will lead to wound dehiscence or rupture of wound, and later on it will ulcerate. And there is excessive formation of components of repair process can give rise to hypertrophic scars and keloids. And sometimes the exuberant proliferation of granulation tissue will block reepithelialization. Okay, it may also prevent the wound healing. I mean, it leads to prolonged wound healing. So this is called as, otherwise called as a proud flush, exuberant formation of granulation tissue. So this is the picture of a keloid. You can see that there is excess amount of production of collagen at the site of injury. You can see the microscopic picture, a lot of collagen arranged in the haphazardly. So usually the collagen will be in parallel with the surface epithelium, but if you see the collagen, it is arranged haphazardly and there is an excess amount of collagen deposited in patients with keloid. So this is also another picture of a keloid. You can see the raised thickened scar over the dorsum of hand. So unlike hypertrophic scar, the keloids grow beyond the borders of the original wound and are refracted to the medial line. surgical therapy. Okay, so this is the problem with the keloids. Sometimes what happens is, especially in abdominal surgeries, in the female genital tract, especially lower segments, cesarean sections, what happens is, so there is a excess amount of fibroblastic proliferation resulting in the formation of desmoids or aggressive fibromas. This is very actually very problematic. Okay, so again, this desmoids are of three types: extra abdominal, abdominal, and intra-abdominal. The after all, intra-abdominal is more problematic because there is this excess amount of myofibroblastic will proliferation will encircle the major organs like kidney, liver, and so it will cause a lot of problems within the abdomen. So this is very problematic. Okay, intra-abdominal desmoids are very problematic. Next, contraction. Contraction in the size of wound is an important part of normal healing process, but an exaggeration of this process gives rise to contracture and results in deformities of the wound and the surrounding tissues. Contractures are particularly prone to develop on the palms, soles, and anterior aspect of thorax. And contractures are commonly seen after serious burns and can compromise the movement of joint. So let us see a pic. You can see here. You see this is a case of burns. You see there is a flexion deformity here. So actually, because of what? Because of the wound contracture, the joint, so the extension movement has impaired and it results in flexion contracture. Okay, so these are the various complications of a wound healing. So I hope I revised the important questions which are given in the last lip test. So anybody having any questions, please you can ask. Anyway, I will post this presentation in your group. Okay, you can revise if you want to revise. Thank you so much for your patient hearing.